Greetings everyone and welcome to the online Optom Learning Series session. Welcome to the 87th session of the online Optom Learning Series. Let me introduce to everyone our speaker for today. So today we have Dr. Priya Morjaria. She has a BSc Honours in Optometry from the City University, UK, followed by a MPH in Eye Care and a PhD in Public Health for Eye Care from the London School of Hygiene and Tropical Medicine. Her special interests are in public health and school eye health screening programs. She has over 14 years of experience now from community, hospital teaching, and public health in optometry. She is also the recipient, and I think the only recipient of the award which is given by the World Council of Optometry, which is known as the Paul Berman's Young Optometrist Award. This is a prestigious award which is given to any young optometrist who has made an outstanding contribution over the time to the achievement of the World Council of Optometrists' vision and mission. And she's been the only one, I guess, up till now to have the privilege to receive that award. She has done a lot of clinical work in terms of eye care research in developing countries, which includes Bangladesh, Ethiopia, Kenya, Malawi, Nepal, Zambia. I think the list goes on and I just stick to those. And with that very, very vast experience in community optometry, today, she is going to talk to us about the importance of community eye health in optometry. And I would welcome Dr. Priya onto our platform. Thank you so much for giving us this time. And let me just leave the screen time to you now.
Thank you. Thank you for the introduction. I think I want to start with a poll. Okay, I have, can you see that? Okay. 15 of you, I'm going to not try and attempt too much, so I'm just hoping you can see this. 15 of you have voted so far. So I think 22 have managed to vote. So what is public health? And there's probably quite a few definitions you have heard recently just because of coronavirus and COVID-19, and you've had in your various countries different public health professionals making decisions for the whole country as to lockdown. And, you know, in the UK, our body is called Public Health England. You know, a few days ago, we were told that there's a new strain of the COVID-19 virus. So that information comes to us from our public health body. In the US, it's called the Center for Disease Control and Prevention. So there's various different things that go into public health. It was really, really nice to see that when you were all voting, you know, the few people that did vote said that they do call themselves a public health professional. I don't usually get that response from optometrists, so it's really nice to see that. Okay, so public health is defined as the art and science of preventing disease, prolonging life, and promoting health. And that's why I see optometrists as public health professionals, because we know the art and science of preventing disease and promoting health. And the reason why we can do that is because of the whole basis of public health is epidemiology. Now, epidemiology is the study of the distribution and determinants of diseases in populations. So, you know, at the moment, we keep hearing a lot about coronavirus, you know, the R rate, how quickly it's progressing, how many new cases there are per day, what's the prevalence in a given population. And so those are different terms that you probably hear at the moment. So epidemiology is the quantitative discipline that underpins public health. And it often defines the organized efforts of a society to prevent disease and to promote health. So at the moment in the UK, we're seeing a lot of promotion around have more vitamin D, because it's apparently, who knows the link yet, whether it helps with those who suffer from COVID-19. Apparently it then reduces the after effects of that. So that's all public health. As practitioners, now, because I have to show my slide in this way, you might not be able to see it. But the assumption is that there's a patient who requires treatment, and that's on this side here. And they go through the system, and all of them come out having received their treatment. And that's what we expect. As optometrists, as clinicians, we find a patient has an eye problem, they go through the system, and they're going to receive the treatment, come out happy on the other side. But actually, that's not what really happens. What happens is maybe 3 people need treatment, and out on the other side only comes out 1 having been through the system. And there's a public health phenomenon that describes why this happens, and we call it the leaky pipe. And that's every time you walk through a system, there are lots of places that you can fall out. And what usually happens, and I'm afraid I can't show you the animation on this, is that what you would see is that 3 people are going in and 2 people are falling out at different points, and only 1 person is coming out. And so I'll talk from my personal experience as someone who practices in the UK. We have a system with our general practitioners. So a patient goes to the GP with a headache, and they recommend that they come see an optometrist. Now, the GP assumes the patient is going to go and do what they're told, and that they'll come and see me because the GP thinks maybe their problem is to do with their eyes. We refer a patient through the hospital service. I refer a patient for cataracts, and I can do that here in the UK either directly or through the GP. But I refer the patient, I write to the hospital, I let them know, and then I assume that my patient went to the hospital for their appointment. I advise a patient of a treatment, and I assume again that they agree to the treatment and they're going to comply with what I told them to do. So, we get a lot of dry eyes here. So I tell my patients to use hot compressors, I tell them to clean their eyelids, and I assume that they will do exactly what they are told. But experience shows me that such assumptions are often far from the truth. How many times have you sat and taken history and symptoms and found that a patient is struggling to see because they're not using the spectacles you prescribed them or someone else prescribed them? Or their eyes are still dry because they didn't go and purchase the eye drops that they were recommended. So there's lots of scenarios like this that happen where we assume a patient does as they're told, a patient will go through a system as they're told, but that doesn't happen. So I'm just going to share another poll on
share. So yeah, 70% of us of the attendees say yes, we always relate to these kind of experiences. And about 30% say probably they have not, probably they are young practitioners maybe.
Or they've got a perfect seamless system.
Yes.
Okay, thank you. Fine. So I will remove that. Okay, so a lot of you can relate to this experience. And that leads me very well onto, there can be many reasons why, I showed my screen too early. There can be many reasons as to why a patient is not accessing the treatment you told them to access, is it maybe they can't afford it, maybe they don't know where to go, maybe they didn't fully understand what you were saying. So there's lots and lots of reasons for this. Now, there's a term called universal health coverage. And I'm just going to, again, I'm going to start a poll on Slido. You should be able to see this new poll active on your Slido. What is universal health coverage? So this is a free text option. Just write down any words that you think come to your mind as to what is universal health coverage. If you've heard of the term, if you haven't, take a guess. What does it mean? And it's a really important public health principle, something that us as optometrists need to be aware about. Yeah, I can see providing health to all, equal to everyone. Great answers. Yeah, everyone should have equal health benefits. Great. So there's some of you, as you can see, who who are saying the same thing. And what Slido allows us to do is to be able to see which opinions are coming in as the highest ones. As a lot of you said, universal health coverage, it means that all people have access to the health services they need, when they need it, where they need it, and a really important one, without financial hardship. Okay, and that includes a full range of essential health services, from health promotion to prevention, treatment, rehabilitation, and palliative care. Now, having just read that definition, if you could just reflect and maybe put yes or no answers in the chat box. Do you think that the service you provide as an optometrist meets the definition of universal health coverage? Now, I know it varies from context, countries, setting you're working in, but just have a quick reflection and maybe just put it in the chat box. Do you think your services meet the definition of universal health coverage? So I'll be very honest with you. I don't think many places actually meet that definition of universal health coverage. Not even where we're working, where I work here in the UK. And that's because not all services are always available to our patients when they need them. So we have at the moment, we rely on our National Health Service. And it's got a huge backlog. We've got staff shortages, lots of staff shortages. And so we have sometimes patients who are waiting on a waiting list for up to 6 months for simple, maybe even cataract surgeries. So as a country, the UK, we're also struggling to meet universal health coverage. Now, thinking about my own services, when I practice as a clinician, I sometimes feel that my patients don't always get the service they require because maybe they can't afford the glasses that they've been told to get. And so it puts them into financial hardship. So, have a real think about these definitions. Do you really think that you're providing universal health coverage in the areas that you're working? So these are some really basic principles of healthcare. So I'm going to do another poll now. Fakhruddin, I think you can put this one up. Have you heard or read the World Report on Vision?
All right. So yeah, majority says no. 53% of them says they have not heard or read about the World Report on Vision, whereas the rest 47% who have voted says that they have.
Brilliant. Okay, so what I'm going to do is, for those who've read about it or heard about it, that's fine. But what I'll do is I'll quickly explain to you what the World Report on Vision is. So the World Report on Vision was published last year on World Sight Day on the 9th of October 2019. And it was a report that was published by the World Health Organization. And it's a very key report, and it was at a timely milestone in prevention of blindness. It's a report that informs and persuades global leaders about the magnitude and unacceptability of unavoidable vision loss globally. Now, the reason why I'm telling you about this report is because this report talks about optometrists very specifically. It includes us as a profession in this report. And it mentions us specifically because it advocates for the need for integrated people-centered eye care. And this refers to eye care services that are managed and delivered to assure a continuum of promotive, preventive, treatment, and rehabilitative interventions against the spectrum of eye conditions coordinated across the different levels and sites of care within and beyond the health sector and according to their needs throughout the life course. That's a mouthful, so I'll break this down. Basically, it's saying that any care that's provided within eye care should be integrated and people-centered. And so that means that a patient should be able to access eye care services at primary eye care, secondary and tertiary, and those services should be a continuum. So if I'm referring my patient from a primary level, so if I'm an optometrist working in primary eye care and I refer my patient to either secondary or tertiary, they should receive a continuum of care throughout this process for all their conditions. And it's not just their clinical needs, and it's about health awareness, making them aware about certain conditions or making them preventative treatment, etc. So that's what the World Report on Vision talks about. What it also does, it is defining services that are managed and delivered so that, like I said, people receive a continuum of care. It addresses all their eye conditions, and it recognizes that people are participants and beneficiaries of these services, rather than just seeing them as a number. It recognizes that as people, these are participants and beneficiaries. Now, how does this apply to us in eye care and as optometrists? So if you think about our services, we identify that patients have a problem, whether that's in your community or in some cases where there's school eye health programs in schools. They are diagnosed with a problem that they require a service, and that's done by either an optometrist, refractionist, other allied health professionals, and that the name varies in lots of different countries, so I won't get into that now. They receive a service, and that's again by this group here, and that can include ophthalmologists, and they receive, it has an impact. And so at each stage through this, people go through this process, and that's a continuum of care, and that's people-centered eye care services, where you walk them through a system from identifying they have a problem to them diagnosed with what the problem is, receiving a service, and then the impact it has. And impact is things like, do they need spectacles? Do they receive them? Do they require medication? Do they receive the medication? Now, again, you would think this is quite obvious in our profession, but like I said, it's like a leaky pipe. People don't always go from here to here as we would expect them. And what the World Report on Vision stresses on is that there should be a pathway that goes from here, from the community, all the way to tertiary care. And at each point, there should be an eye care integrated professional. And in a lot of cases, and the World Report on Vision describes this, these needs can be taken care of by the optometrist. So you can find optometrists at all of these levels. And so it's just remembering that we are part of what is being advocated for. We're part of these integrated effective referral pathways that's been advocated. There is no single referral pathway for countries. And so that really depends on the setting, and it can also make a difference what the legislation is in different places. But that's what the report advocates for. Something else the report talks about is information. Now, you don't know how you're performing if you don't have the data to say how you're performing. If I asked you, how are you feeling? And unfortunately, maybe I can. Let me just ask you now, just put it in the chat box. How do you feel right now? And just put one word in the chat box.
Probably some people
I'll say to you, I feel really anxious because I'm working off a new computer. I can't see my slides. I can't see my notes. So I'm just walking through this. So I must say I'm feeling very anxious.
It's quite late here in Malaysia. Maybe some people are sleeping, if that's the answer you're looking for.
Sleepy, hungry, tired.
Yeah, and I think
that they started so late, and it's maybe you had some other plans.
Yeah, we got some responses, so they feel interested. Somebody relates to me as well. That was just a joke and a comment about sleepiness, but
okay.
Interesting, energetic, good.
Okay, so now you're telling me how you're feeling, but you can only tell me how you're feeling right now You can't, and you're comparing it to something else. So if you're feeling sleepy right now, it's because you know what it feels like not to be sleepy. You're telling me that you're feeling energetic because you also know how it feels not to be energetic. So you've got some information, you've got some data, you've got a baseline to compare it to. I asked you if you heard my question carefully, I asked you how you're feeling right now. I didn't ask you how you were feeling an hour ago, 10 minutes ago, but just right now. And the reason that that point is important is because often enough, we're not collecting the right information when we're giving our services. Now, there's key components and building blocks that are part of a health information system, and they then help us to understand the impacts and the determinants of health. Health systems have lots of different things that go into it. There's governance, there's financing, there's human resources, information. That then makes services either accessible, available, affordable. And that then leads on to whether you've got good coverage of a service or your services are being utilized. Now, all that data is really important. And a well-functioning health information system ensures that you've got data that is used by clinical decision makers regularly. So what should we measure? But this is really important to understand. As someone who practices, how often when you've got a patient in front of you, have you ever stopped to think, wait a minute, how did my patient get here today? What prompted them to come? What challenges did they have to overcome to be here today? Are there many patients like this one patient who I don't know about? So we never really stop to understand the holistic nature of a patient. We've got them in front of us. We do our refraction. We do our slit lamp examination. We look at the fundus. You might have an OCT. You do an OCT measurement. But do you ever stop to think about how did this patient get here? And universal health coverage wants us to understand that so that we can understand better some key data points. What is the unmet need in our population? What is the met need? And what are the barriers to healthcare? So in our case, eye care. And we can translate this into some very measurable parameters that are quite easy for us to remember. So that's coverage, adherence, and effectiveness. And I'll just explain those in the next slide. Coverage. So that means of those with an unmet need, what proportion identified through either screening or self-identification? Now, if you work in a practice or, whatever setting you work in, it's usually people who have self-identified and have come to you because they have a problem today. If you work in certain community settings, it might be that there's large screening programs and patients are told to come to you. So basically, of the people that have a need, how many of those are actually turning up and sitting in your chair? That's your coverage. Adherence. Of those that have a need and you need to refer them to the next point in the health system, what proportion actually make it? So if you think of my leaky pipe, what proportion actually go from A to that part at B, and how many are falling out? And then effectiveness of those who receive an intervention, for how many of them has the intervention worked? This is really important. And as I said to you before, I can tell someone to wear their glasses. I can tell someone to put in their eye drops. But if they're not doing it, then have you actually dealt with the problem? And so has the intervention actually worked? And so I'll walk you through an example. This might wake you all up. We'll do a little bit of maths. Okay. So we're just going to work through this example. So let's say there's 100 people in your population that have an eye problem. Out of those 100 people, you do a bit of screening and you manage to find 80 of them. Okay, so I hope you're all following me through. So you've found 80 of them, 20 of them you've not been able to reach. Okay, so your coverage is 80%. Okay, so out of those 80, right, 40 of them, so that's 50% of them, have adhered to a treatment. You told them to have a treatment or to go to the next place, they had to go to referral, sorry. They were referred. Now, 80 of them were told they need to be referred, but only 40 of them actually came for their referral. So half of them didn't even come to their referral for various reasons, and this is why it's important to remember there's lots of things that go into provision of health services. Out of the 40, 30 of them actually, 10 of them, the treatment was not effective. So you gave them a treatment and only 10 of them it didn't work on. So now you just think about it. You started with 100 people that required a treatment and you knew they had a problem. And in the end, only 30 of them are the ones where you've had effectiveness, because not all of them got through the whole system. So this should help you understand, there was a need, and coverage is of those with an unmet need, how many are identified? And then adherence is of those that you identified that had a need and referred, how many actually make it? And in our case, we found only 50% of them made it. And then effectiveness is of those who receive an intervention, what proportion has the intervention worked? And so if you start thinking about that when you're practicing, you'll start to notice that actually, you need to be thinking a bit broader with what you're doing. You need to be thinking of all these people here rather than just those, maybe by the time they reach you or you're here, only these ones are actually making it to you. What I'll do is I'll just move on and talk a little bit about the World Report on Vision again, a little bit, and what it says about optometrists. It talks a lot about optometry, and it says that although the private sector, and again, this is no different from any other place, the private sector makes up a significant proportion of the provider landscape, but the exact share is rarely understood. I've worked in a lot of settings where optometry care, refraction care is provided in the private setting and not in the public sector. And such a large part of it is provided in the private sector, and the problem is being dealt with, but people don't know what proportion of the problem is being dealt with. So one of the issues is that the problem with us as optometrists, and it's quite a controversial topic, is it's sometimes an uncoordinated and unregulated workforce. And sadly, I've worked in many settings where there's so many definitions of optometrists. There's 3-month courses, there's 3-year courses, there's 1-month refraction courses, there's all sorts of courses, and it becomes an unregulated workforce. And so you get a lot of inefficiencies and gaps and poor outcomes as well. I've worked with optometrists who don't know how to do refraction when a patient has astigmatism. They can only refract spheres. When there's complex refractions, something even over -5, they're not able to refract. And that's just because that's the training that they've received. And so that's also a problem. There's lots of innovative strategies that have emerged, and they're where they use community-based workers, such as optometrists, to deliver eye care and vision services. This impact is hindered because of the lack of coordination, regulation, and systematic integration. Now, these are direct quotes from the report, and this is pretty true of optometrists, because, as I said, there's lack of coordination, regulation, and there's lots of times there's lack of standardization of care as well. And this goes right to the training. Despite significant progress being made in promotion of training standards for optometrists, etc., it remains an issue in many countries, and it's an important advocacy issue going forward. In some places, and this is something I've come across, where optometrists are trained to do things like cyclopedic refractions, or they are trained to use mydriatics. but they're not accredited to carry out these services independently. And they can only do that under the supervision of an ophthalmologist or a physician. And so that really hinders the productivity. Imagine if, for myself, I do a cyclopedic refraction a few times a day. If I had to wait every time that I needed supervision to do that, imagine the loss of productivity that may cause. And then one of the other things that's really clear in the World Report on Vision is that there was a review that they did in Trinidad and Tobago where they found that 80% of all eye care in the country was coming from the private sector. But only 20% of the population had health insurance. And private sector work needed health insurance. So you can imagine how it would be unsurprising that a lack of health insurance was a key factor for vision impairment amongst adults. So all of these things are important to address for universal health coverage. And it's something we are going to have to deal with because we have an increasing population, an aging population. So we have people who are living longer and a lot more people. And we've got a lot of environmental and lifestyle changes. Just over the last 9 months, I've seen so many children who are doing so much more screen work, phone, online learning, schooling, and it will definitely have an impact on their vision. And as a primary eye care provider, that is us as optometrists, we should be the ones that should be able to deal with these problems sooner. An aging population will require diagnosis of cataracts, diabetic retinopathy, glaucoma, macular degeneration. Those are all conditions that as primary eye care providers, we should be able to screen and diagnose. I'll do one more poll, and that is...
and just give us your thoughts on, do you practice evidence-based optometry? Okay, now the polls are running quick. I think good.
Yeah. And don't overthink it. And right now there is no right or wrong answer. Just what do you do at the moment? Do you think you practice evidence-based optometry? And you can see the results as they're coming in. Okay, so and so yeah, that was a Slido poll just to do that. Okay, so it was overwhelming to see that most of you, those of you that voted, that said they do practice evidence-based optometry. Now, but what I'll do is I'll just give you a little brief summary of why I was asking about evidence-based optometry. So I did a trial in India, and that was to see when you give children their glasses, do they actually wear them? Now, this is a really sticking point with a lot of people because whether you're in the UK, whether in the US, in India, Africa, anywhere that you are, I have always found that spectacle wearing rates are really low amongst children. And there's lots of reasons why, it's because they're teased, they're bullied, their parents don't want them to wear them, they're expensive, they don't like the look of them. So it's so many reasons, and I think this is a universal problem everywhere. Maybe you can just put in the chat box if you agree or not. Yes, no, is this a problem that you've encountered, that children don't like wearing their glasses for various reasons? Yeah, just put it in the chat box. Agree.
Agree, okay, yeah.
Great, so I saw one or two answers coming in, so that's good. So, okay, so it is a common problem. So it's not just something I face. So I did some work in India where, and I won't talk you through the whole trial, I thought that if I could do some health education for teachers, parents, children, then it would increase them wearing their glasses. So I did lots of things. I did some classroom education. I got these little photographs, film posters. We used children playing. We used the Indian cricket team. So we did lots of these, and I made a lot of these postcards like this. And we did a trial, and we sent postcards like this home with a child when they needed glasses. We tried to mitigate other factors, so we let the child choose her frames so that she would wear the glasses that she had chosen. We entered all this data quite quickly in real time, and that's why I asked you about whether you practice evidence-based optometry. So I would get this data in every day, how many children had I screened, how many spectacles had I given, how many had a referral, how many had refractive error. So I did all this. I did lots of work for a whole year. I sent voice messages to parents. So their phone would ring and there'd be a voice, like a celebrity, who would say, we saw your child for an eye test. We've given her glasses. Can you make sure they wear them? Or we've referred your child to come to the hospital. Can you bring her? So I did for a year, I did all this health education just to increase spectacle wear. And in the chat box, can you think about what happened? Do you think spectacle wear increased, decreased, stayed the same? So just in the chat box, just put an answer.
So after all the efforts, you took out these pictures, send it across to home to the parents, got them voiced message. I think that's quite a lot of work.
Oh yeah, it was a lot of work. We did a lot of focus groups. We spoke to parents, teachers, children. We asked children why they would bully other children.
Mm-hmm. Yeah. So,
okay, so quite a lot of you are saying you think it increased, yeah?
Yeah. Majority has increased. A few said decreased as well. So, yeah.
Yeah. Okay. So let me tell you what happened. It stayed pretty much the same in both arms. So because it was a trial, I was comparing one arm where we did none of this, and in one arm we did all of this. So in the arm that I did all this work, 53.6 children were wearing them, and an arm where I did none of this, only 52.9 were not wearing them. So it was so similar, and I was quite upset actually. This was a trial, and one of the trials I did in my PhD, where I wanted to prove that doing health education creates behavior change. So I was very upset about this. In the chat box, if you want to write, why do you think this happened? Just one reason, if you can think of something.
So now that you know that it did not increase, it almost remained the same. Whether you did some intervention of, doing all that efforts, or you didn't do anything, what do you think could be the reason? Just what are your thoughts about this, right?
Yes, exactly.
Yeah.
And honestly, there's no right or wrong answer, because I still don't know the complete answer. I know a bit of it.
Yeah.
So, yeah, maybe that the parents one is a very important one. Yeah.
Mm-hmm. So says parents are involved, maybe they do not want the child to wear. So that's a social barrier, if I may put it that way.
Yes. And that was one of the barriers we identified.
Okay, that's good. Anything else? Somebody else wants to.
Social stigma, yeah. And think about all the work I did. So remember, I sent them voice messages, I sent them all these postcards, I did a lot of interviews, I called the parents into the school, I did education in the classroom with all the schools. Okay, so you've got social stigma. Some will go for contact lenses. They would, unfortunately, in the setting that I was working in, that wasn't an option. But yeah, that's an option that does happen. Many are orthodox, yeah. So similar again to the social stigma. Okay, so I will tell you what happened because it really bothered me for a while. Now, and this brings me back to the full circle about we make so many assumptions when we're providing our services. I did all this work and I sent, letters home, images home, voice messages home. And in the end, it turned out that of all the children that I sent, only 28, so just about 14% of those children took the letters and the images home. The rest of them didn't take it home. They didn't show their parents what had happened. They didn't take this letter from school. They didn't take the image. And, you know, it was quite and the ones that, you know, who received the voice message, they understood it. Most of them understood it. But because they didn't have all the other information, they didn't know what had happened. Now, this is really important. All the assumptions we make when we're providing our services are just assumptions. And that's why we need to practice evidence-based care. You know, that's why, and I'm not saying we need to carry out trials. All I'm saying is that we need to find out from the patients that we're working with, what are their challenges, what are their barriers, and whether they're actually receiving the service that we intended for them to set out to get. And so that was a really important lesson learned. And it was surprising. And I'll just put up this slide because I have to. These are all my funders and collaborators for my trial. In summary, again, apologies for the delay, but in summary, as optometrists, as some of you rightly said, we are public health eye care professionals. We do need to practice evidence-based clinic. Our practice should be evidence-based, and that means collecting data, analyzing data, and disseminating it. And when we do that, it can quickly enable us to make changes to the services we're providing. So in programs that I work in, we collect data, it helps us to then improve the services. Try and think about the services you're providing and collecting different data points. So the coverage of your service, the adherence and the effectiveness. If you can even start with collecting one data point, and that's coverage or adherence, then you're miles ahead of other services. And if we collect this data globally in a standardized way, then we're able to measure our work and improve our services and provide an input into the problem. Thank you so much, everyone.
Thank you so much. I think the message was very clear. We have to always remember that primary eye care practitioners as optometrists, we have a very huge and a big role to play. And I think the data what you shared is really going to help many of us to shape our future decision makings and how to go about practicing, right? So thank you so much. And so just one comment on which I was, if I may put it that way, these are just my thoughts on how public health and the optometry relates into. Does it need to have a dispensing arm, or do you think just providing clinical services, just eye examination, is a part of public health, or do you think it should be associated with dispensing arms, such as giving them glasses? It should be like a package, or what's your thought on these aspects?
So it's a very, very good question. I'm just working at the moment on a paper where they talk about cataract surgical outcomes. And the patients are going in for cataract surgery with a vision of, let's say, I don't know, 660, okay? And post-cataract surgery, they're going home still with maybe similar vision or just a little bit better. And what they found is because most of those patients are not getting refractive care. And so absolutely your services should be both clinical, as in doing the refraction, and then provision of the treatment. And that's one of the basic principles of public health as well. If you're going to diagnose and identify someone with a problem, you must provide a service for it. Now, whether that's linked to your service or you need to send them somewhere else, but there should be a whole package of that. And so one of the public health principles is no screening, so no identifying someone without a service. And a full service is only when that patient is leaving with their vision better or their intervention having reached them.
So, the thought comes because what happens is sometimes we may be very good clinicians, we might do the best refraction in the world, but then if we are not able to, put it across as, if you're talking about kids, if you don't give them correction, you're not doing anything, right? And the other part of it is we can also be, if you, as you said, you may not be able to provide all these services. This probably may open up doors for more collaborations with other fellow practitioners and eye care providers, right?
Yeah, completely. And one of the things that the World Report on Vision stresses on is exactly this collaborative care, working with other specialists, with other clinicians, with other service providers. Even and it's a term that's used so much, private-public partnerships. But usually you find in some places that the refraction is done in the public sector and the glasses are in the private sector. How do you bring that together? How can that work collaboratively? How can that be a business model that works for everyone while still providing the service? So those are definitely really key questions that come up.
That's right. And one more thing, I think this relates to the previous session, what we did on pediatric dispensing ago. We did a session specifically on pediatric dispensing, and we did touch the role of optometrists in terms of pediatric dispensing. I think this thought relates to your your study, what the trial, what you did. So the speaker did mention that giving kids to choose their frames is, I mean, the same thing what you reflected in your study plays a very important role, because they will actually like to wear that, and probably that would be one of the thing which we would look forward to or put it up into practice, right?
Definitely, always. Even now when I'm in practice and I see the parent choosing the frames for the child, automatically, that child's not going to wear them. The first thing the child, if he doesn't like the look of them, I mean, even myself, if I don't like the look of these, I'm not going to wear them. I chose them, so I'm wearing them. And it's the same with children. So it's always remembering that.
Any thoughts on putting public health model in a practice which is more of an optical store based practice? Can we still do that? Is there any tips on how can we do public health in an optical store setup?
Obviously it's very different in all these contexts, and I've worked in Asia quite a bit, so I know how difficult this is. But one of the things that's worked in Trinidad and Tobago, what works is that the optical store becomes a preferred partner. Yeah. And so when the refractions are done, or there's a link with a hospital or an ophthalmologist, that optical store is a preferred partner. And that's one way of doing it, and that's a model that works. The other model that works is by the optical store being part of the public service. So it has almost like a little vendor station within where the public hospital is. And so there's lots of different models that work, but it has to be very context specific, because of regulations in different countries as well, and things like that. But yes, it does work.
That's right. Okay. Thank you, Dr. Priya, for doing this for us.
Thank you. Thank you very much for having me.
Yeah. So to the attendees, we do have session tomorrow. This is on practice management again, and the speaker is going to share some tips on how to build up a healthy practice, which could be a key to success. So thank you everyone for attending. Thank you, Dr. Priya, again, once again from the entire team online Optom Learning Series, as well as the attendees, for taking up your time on a Saturday afternoon in the UK and doing this session for us.
Thank you.
And take care, everyone. I hope to see you all again tomorrow. Be safe. Bye-bye.